it cardium. So both the diastolic and the systolic component of the myocardial function. And again, it's called the tie index or MPI or LIMP, which is left ventricular index of myocardial performance. So the important thing here is knowing the definition, because once you know the definition, then you can work out what this thing looks like. So again, the definition is, and you have to use the Doppler, okay? You have to use Doppler to get a clear understanding what MPI stands, what MPI is. It is the interval from from the mitral valve closure to the mitral valve opening. You're going to subtract from that the ejection period or ejection time, and you're going to divide by the ejection time. Okay, so you need your apical 5-chamber view, and let me just show you exactly. So again, so it assesses the overall myocardial function, that is systolic and diastolic function. I'm going to show you the PW method, but you can also do it using Doppler, okay? But I think it's much better understood using PW. So first we'll look at LIMP, which is left ventricular index of myocardial performance. Then we'll look at RIMP, which is right ventricular index of myocardial performance. All right, so you need to get your mitral inflow, and remember, when you're doing your mitral inflow, is at the mitral valve leaflet tips in the 4-chamber view to get the mitral inflow, because we talk about mitral valve closure to mitral valve opening, and we remember now we're talking about Doppler, pulse rate Doppler. So 4-chamber view, the sample volume is at the mitral leaflet tips. And then in order to get the ejection, you have to do your 5-chamber view, is the ejection period or ejection time. All right, so let me so this is what you should be visualizing. So when you do your mitral inflow, okay, at the mitral leaflet tips, you know that this is your mitral inflow. You get your E velocity, then your A velocity, okay, then the mitral valve close. Okay, when the mitral valve opens, blood is sucked in from the left atrium to the left ventricle, and you get your E velocity. Then there's a period of diastasis. Then the atrium contracts to give you the A velocity. Then the mitral valve close. Okay, when the mitral valve close, then that period of time before the aortic valve is open that period of time is what we call the isovolumic contraction time, ICT. Remember, it's from basic cardiac physiology when we just started echo. So, and then the aortic valve opens, then you get ejection across the aortic valve, okay? The blood accelerates and then it decelerates. This is the ejection period. So this is the ejection period. Then the aortic valve closes. But before the mitral valve opens, the LV is relaxing. So this is your isovolumic relaxation time. Just before, then the IVRT, then the mitral valve opens, and again, suction of blood from the left atrium into the left ventricle, diastasis, the atrium contracts, A velocity. So all of this is your PW settings. So what you need to get your apical 4-chamber view. And remember again, we're looking at the mitral inflow. So the sample volume should be placed at the mitral leaflet tips. So the mitral valve opens, in diastole, close, and then IVCT, then ejection, IVRT, then the mitral valve opens again. The definition for MPI or limb is from the period of time from mitral valve closure to mitral valve opening. You're going to subtract from that the time. But if you just do the mental math, you can see that that's going to leave you with ICT plus IRT, okay? And you're going to divide that by the ejection time. So when you simplify the definition, the index of myocardial performance is IVCT plus IVRT divided by the ejection time or ejection period, okay? Okay, so that is it. All right, so you have to get this concept. You have to be very clear about this concept. All right, so again, IVCT, isovolumic contraction time, IVRT, isovolumic relaxation time. The normal value for limb is 0.39 plus or minus 0.05. Okay, so this is the normal value. So you can get an increase in your myocardial performance index in patients with a spectrum, all spectrum of heart disease. Remember, your MPI look at overall heart function, systolic and diastolic. Okay, so you get an increased value in a lot of sick hearts. RIMP, which is right ventricular index of myocardial performance, is very important in patients who have primary pulmonary hypertension. Some facility use this measure to follow their patients. All right, so that is MPI tie index. Okay, need to know a little bit about it. Then we're going to look at another means of assessing cardiac function, and that's a so-called DPDT, the ventricular contractility assessment. And again, you need to follow this because it not only appears in exam, but depends on the institution that some of you guys are going to be working in. They may require you to do this. Okay, so the ventricular contractility assessment, basically what you're doing, you're seeing how well the ventricle is contracting. So you're looking at the change in pressure with time. For a normal ventricle, so you're going to visualize this now. If you have a ventricle which is contracting strong, then you're going to have a fairly large change in pressure with a small period of time. So a big number is a good thing because you have a huge change in pressure with a short duration, okay, as opposed to a weak heart. So if you have a weak heart, it's going to generate not a very high pressure, and it's going to take a long time to do that. So DPDT is going to be a small number because it's going to take a long time. So the heart is weak. It's going to take a long time to generate a sufficient pressure. Okay, so DPDT assesses global LV contractility. You can do it on the right side as well. So, but we're looking at the left side right now. So it assesses the global LV contractility. And as mentioned before, it's the pressure generated in the LV during the isovolumic contraction time. It's the pressure generated during that time, IVCT. So when you're doing your DPDT in the echo lab, you need to use your MR jet. So you need a mitral regurg jet. and you're going to increase your sweep speed to 100 millimeters per second. So you're going to increase the sweep speed. And you need C doubler, okay? And you're going to adjust your velocity to about 4 meters per second. So these are the things that you need to remember. Sweep speed, increase to 100 millimeters per second. You need a C doubler, and the velocity, you're going to adjust it to about 4 meters per second. What you're doing, and when you put these information in the computer in the Ecolab, it will generate a DPDT. But you can do it from first principles. You can do it from scratch. What you're doing, you're calculating the change in pressure with respect to time from 1 meters per second to 3 meters per second. And just follow me. It is not as difficult as you think. Just follow me through with this. All right. So we're going to explain what all of this means. So let me go. All right. So sweep speed, 100 millimeters per second. You need an MR jet. Okay. And let me do it in the cartoon first, and then we can go to, okay. So you have mitral regurgitation. It's a systolic phenomenon. So this is your MR jet. This is the MR jet. Time is on the horizontal axis and velocity is on the vertical axis. Okay? So when you get your MR envelope, okay, normal MR usually go to about 5 meters per second or more. Okay. You want to assess your MR at 1 meter per second and 3 meters per second. So again, remember, velocity is on the vertical axis. So where you have 1 meter per second, you come across and see where it intersect your MR envelope, and then you draw a perpendicular or a vertical up to the time axis, and then at 3 meters per second, you do the same thing. At 3 meters per second, you get your velocity, you come across where it intersects your MR envelope, then you go vertical to the time axis. So remember the definition. You're going to see how the change in pressure with respect to time. So remember, when we talk about the velocities, we can convert velocity into pressure gradients. So essentially, that's what you're doing. So at 1 meter per second, you have a pressure gradient associated with that. At 3 meters per second, there's a pressure gradient associated with that. Using the modified Bernoulli equation, gradient is equal to 4v squared. So at 1 meter per second, you square the 1, that's 1, times 4, so that's 4. So the pressure gradient at this 1 meter per second is 4. Okay? At 3 now, at 3, the pressure gradient here is, you square the velocity. 3 times 3 is 9. 4, 9 is 36, so the pressure gradient here is 36. So the difference in the pressure gradient from here to there is 36 minus 4. Okay? Okay, the pressure gradient at 1 meter per second is 4. Pressure gradient at 3 meters per second is 36. The difference is 34. So if you're going to generate a pressure difference of 34, how much time is going to take you to do that? You can, if you have time and you can sit down, it's going to take this time because you already did it from first principles on the MR envelope. Again, at 1 meters per second, you have the gradient. At 3 meters per second, you have the gradient. Once you go vertical, you get the time. So this little time here is the time it takes to generate that pressure gradient difference. Okay? And if you can measure this time, then that's your dPdt, change in pressure with respect to time. Because the pressure is going to change from 1 meter per second to 3 meters per second. Okay, that pressure change, or that change in pressure, is 32. So you're going to convert the velocity at 1 meter per second into a pressure gradient, and at 3 meters per second you're going to do the same thing. Okay, remember it's dp dt. When we say dp, is change in pressure, and with respect to time, how much time it's going to take you to change the pressure from 1 to 3. This is velocity we're talking about. How much time it's going to take you to change that pressure. First principles, you can just go up, get the time, go up, get the time, and you can see the time it takes to generate that pressure. Okay? So at 1 meter per second, the pressure gradient is 4v squared. 4 times, you square 1 is 1, 4 times 1 is 4. And then at 3 meters per second, you get the gradient. You square the velocity, multiply by 4, that's 36. So that's 36 minus 4, it's 32. All right, so again, we usually calculate it from, when we're looking at the LV now, left ventricle, we usually use 1 meter per second velocity to 3 meters per second velocity. We want to see the change. We know the change in pressure. We want to see how much time it's going to take to change the pressure this much. So it is the time it takes to generate the pressure between the 1 meter per second and the 3 meters per second. So the pressure gradient difference, okay? So again, the gradient is equal to 4v squared, the modified Bernoulli equation. So is the change in pressure would be 4 times 3 squared minus 4 times 1 squared. And you'll get, this is supposed to be 32, okay? 32 millimeters mercury. So what you need to get or calculate is the time it takes to generate this pressure. Again, the larger the number, the better the ventricle. The smaller the number, the worse the ventricle. So dPdt should be above 1,000, and it should be between 1,000 and 1,200. Okay? And this is the cartoon we showed you before. So it's basically the change in pressure from 1 meter to 3 meters per second, and the time it takes to get that change. Okay? It's supposed to, a normal ventricle is supposed to take a small time. So when you put change in pressure over time, it's supposed to be a large number, because the time is supposed to be, a good time is a small time. Okay? When you're looking at the right side of the heart, you can do the same thing. dPdt, change in pressure with respect to time. Bigger number is better than a smaller number. But on the right side, instead of using 1 meter per second and 3, we usually use 1 and 2. So the pressure at 1 meter per second, you do the same thing. You square the 1, you multiply by 4, and then at 2 meters per second, you square the 2 multiplied by 4. So it's 16 minus 4, that's 12. And then essentially you're going to find the time it takes to generate this pressure, and then that's dPdt. All right. So you should go over this, and you try and get a very clear understanding, because these things appear in exams, and it depends on the institution. You never know where you'll find yourself, and this may be a routine part of their study. All right, so we're still on coronary artery disease, and we just divert a little bit to look at means of assessing the cardiac function. What about some of the complications that you get with a heart attack? So we talk about cardiogenic shock. That is when the cardiac output falls tremendously. And the cardiac output can fall for a number of reasons. With a heart attack, if you have sufficient muscle damage, and we usually talk about more than 40% of the muscle being damaged, that can affect the overall pumping function of the heart, and the cardiac output will decrease. But you can have other things. You can have a ruptured septum, ventricular septum. You can have a ruptured papillary muscle with wide open MR. So there's a lot of things that can give rise to cardiogenic shock. It just means that the cardiac output falls tremendously, and as a result, the blood pressure fall a lot as well. These patients are very sick. These patients need not only intensive care unit management, but they need some type of intervention for them to survive. Also, we have discussed RV infarcts, RV heart attack on numerous occasions. 1/3 of your inferior wall heart attacks will have a RV infarct. Patients with RV infarct, the RV is very, very weak, and as a result cannot get the blood into the pulmonary circuit for the blood to be oxygenated and then deliver to the left side of the heart. So the pumping function of the RV is impaired tremendously, and these patients can develop cardiogenic shock as well. The important thing there is not to treat these patients like the regular heart attacks. You don't want to give them intravenous nitroglycerin. You don't want to give them diuretics. You have to be careful, because if you use the regular treatment, you can cause harm. Okay. Other things we had mentioned, complications, pseudoaneurysm. That is when the free wall of the heart ruptures, but the blood is contained in usually the pericardium. So the thing that preventing this patient from bleeding out and having sudden cardiac death is the pericardium forms a wall and prevents the blood from leaking completely out of the heart. So that's what we call a pseudoaneurysm. And you need to distinguish a pseudoaneurysm from a true aneurysm. And we always talk about it has a narrow neck. And you can sometimes you can use your Doppler to show that there is a flow of blood from, say, the LV into this cavity. You're going to have a very thin layer of myocardium, and you can use contrast echo to help you as well. So this is what a pseudoaneurysm looks like. So at the apex of the LV, it ruptures, and if it wasn't for this containment in the pericardium, this patient would die suddenly. But the pericardium prevents the heart from bleeding out, so to speak. But you can see that there's flow from the LV across this area into this cystic cavity. And it's a narrow neck, so this is what we call the neck. It's a narrow neck as opposed to a through aneurysm where the neck is a very broad neck. So you can ventricular septal rupture too from a heart attack. So remember, a heart attack is just dead muscle. Dead muscle over time becomes weak and then it completely gives. So, if the heart attack involves the ventricular septum, then the ventricular septum becomes very thin and it can rupture. You can get a VSD, blood flowing from the LV across the septum into the RV. And you just use a color flow to show that. And you get a left to right shunt. And if you use contrast, saline contrast, you can see that there's flow from the LV. Okay. So again, you see a two-chamber view, but you put your color in, you can see that there's a flow right at this membranous portion of the ventricular septum. All right. So, those are some of the more common complications of heart attack. There are much more, but those are the ones that you probably